Good morning, everyone. My name is Desiree Rusted, and I'm the training developer and manager with the Montana Public Health Training Center at the University of Montana. And I'm really excited that you all are able to join us today. And we are going to have a great presentation by Dr. Nicholas Coombs. Excuse me, Nick, sorry about that. He's a former alum of University of Montana, and he is going to dazzle us with data today. So take it away, Nick.
Thank you, Desiree. I love the enter waiting room mark. Keeps coming up here. Hello, everyone. Good morning and welcome. Hope you're all staying warm in your pocket of Montana. I would say the cold in the last week has been debilitating. It's probably the right word. So anyway, today we're going to talk about data. We're going to have an introduction to data and community health improvement planning. I have given this talk for the last couple of years for UM. It has been a constant evolution of sorts, and I am extremely excited to visit with you all today. And the opportunity to convene with the public health workforce across Montana is a welcome sight. So thank you for tuning in. I'll start by giving a quick introduction of myself, and we'll ask for you all to give an introduction as well. So I grew up in New Jersey, born and raised, over on the East Coast. And I did my initial schooling up at the University of Vermont, finished a master's degree in statistics there back in 2015. I did my master's thesis with the Vermont Department of Health, which was my first kind of inroad into health department workforce. There I did a project that got put in their white pages for doing reproducible trend analysis for their youth risk behavioral survey. So that was a good taste into health systems work. When I finished, I moved out to Billings in 2015, where I served as the research statistician for the since renamed Center for Clinical Translational Research at Billings Clinic. It's now called the Collaboration Science and Innovation Department. Being in that role, that was probably one of the best first jobs at a school to have. It gave me a very quick inroad into understanding some of the unique health challenges that exist here in Montana. Challenges that I previously was not familiar with, having grown up in an area of the country that is diametrically opposite to Montana in terms of population, size, area, etc. So that was a steep learning curve and just the best exposure possible. And it didn't take long for me to have a little bit of an itch to continue on with education. So a couple of years after that, in 2017, I moved to Missoula to enroll in the, at the time, newly accredited PhD program in public health. So I finished that up a couple of years ago. My dissertation was an investigation of rural and mental health disparities across 5 dimensions of healthcare access. Doing that work in Montana was timely and appropriate. Montana, as you all I'm sure are aware, is a unique epicenter when it comes to rural health challenges, mental health challenges, and access to healthcare related challenges. So there was a coupling of looking at those domains in the work that I did there. Great work experience, great exposure. And then I moved back to Billings after finishing, so back in 2022. And since then, I've worked across a number of areas of industry as I'm kind of navigating the trajectory of my career. I'm currently leading a private research company that does a lot of work both in Montana and across the country, health systems and clinical work. I have served as a data scientist for Frontier Psychiatry, for those of you familiar. That is a telemedicine psychiatric company that operates primarily, well, as a physical location here in Billings, but it's a telemedicine company that provides psychiatric care to a growing patient population across rural Montana. Real world data experience aplenty there. And then I've done some affiliate faculty work with the University of Montana, School of Public Community Health Sciences, and this past semester, I started teaching statistics at Montana State University up in Billings. So bopping around, doing a lot of different stuff. And that's me in a nutshell. So if you would all be so kind to share who you are, who all is here. I know folks are still kind of rolling in, but if you'd be so kind to write in the group chat with your name, your county of residence, and your organization. Let's all take a moment here for that. Deb, Kate, Josie, April, welcome, welcome, welcome. Thank you guys. Kristen, Elena, Lauren, Stephanie, Larissa, Tammy, Emily, Amy, Stephanie, Amira. Great to meet you all. I really appreciate you all tuning in here. Means a lot. Pam, Stephanie, Lauren, Amy, Casey. Thank you all. Thank you all so much. There's going to be several times throughout this presentation, this training, that I'm going to ask that you type something into the chat. There's going to be a couple pauses to make this as interactive as possible. In the past, we've done this in person at times. Other times it's been remote via Zoom. So obviously the interactive piece is a bit wanting for Zoom, but we try to adjust it as we can. So there will be a couple instances where you are summoned to provide a little bit of information. We'll get to those pauses when we do. Okay. Okay, so when you all registered for this training, during that questionnaire, you were asked to provide a response to the question, what is your number one reason for taking this course? The reason we ask this is because these trainings are designed to be tailored to your needs. Our objective is to make it as useful for you as possible. This is 2 hours of you investing your time for the training center. We want to make sure that you get as much out of this as possible. So we compiled the information, and as of late last week, this is a little word cloud of the words and kind of key phrases that came up in this response. A number of you were had a general interest of learning, getting a better sense of data, understanding, seeing information, health initiatives, data accessibility, stuff like that. And then several of you have also noted that you are in the process of either rolling out or designing or collecting information for a community health needs assessment and or a community health improvement plan. I believe I counted in the responses 8 departments right now, 8 county health departments across Montana that are in the actual process of this based on these responses. So that's fantastic. And having this information at our disposal is particularly helpful because I tailor this training to those points of inquiry. So after giving it some thought, this is the primary objective of today's training: to provide you with a soft introduction to data-driven and community-led decisions for community health improvement planning in Montana. Plain and simple, right? There's obviously a lot that goes into that, but this is kind of how we're framing today's training. I will be following up with each of you individually afterwards via email, and offering up kind of a follow-up regarding anything that you might want to talk about further. So in case there is pieces of today's talk that you are curious about further or learning more, or if you want to kind of have more conversation, I'm more than willing to have those to continue the dialogue with you all. So today's agenda. Today we're going to first we're going to start with an introduction to data. We're going to take a dive into what does it mean to be data-driven? What is the importance of what we call the research question? We're going to learn about different primary and secondary data. And we're going to talk about the Healthy People 2030 initiative. Then we're going to transition over to looking at different ways to use data. We're going to do a little overview on study designs and examples of different studies in the public health sector to explore the questions that you want to pose. And I always include a little nod of causal inference. It's important for public health professionals to understand what you can and cannot infer from work. So it's always good to be to have if either either a bit of a refresher on that or just a reminder of sorts. And then in the back half of today, we're going to take a deep dive into community health needs assessments. We're going to talk about how this is viewed at a federal level with the Community Assessment for Public Health Emergency Response. And we're going to look at a detailed example of a successful implementation of a community health needs assessment that was conducted here in Montana in Carbon County last year. I facilitated that assessment, and I am looking forward to sharing with you all the details around that. And then we'll wrap up talking about community health improvement plans, the CHIP. We'll talk about the implementation funding opportunity through DPHHS and manualizing community health improvement in your respective areas. Keyword, manualizing. We'll get to that down the road. Okay, first off, introduction to data. Let's get after it. So we've heard the term data-driven before, but what exactly does it mean to be data-driven? To be data-driven means to make decisions, to make strategic decisions for your organization based on the analysis and interpretation of data. We do not make decisions based on what we feel, based on what we think. We are informed by the objective information that is provided to us. That is what it means to be data-driven. And why is it important for us as public health professionals to be data-driven? So we may collect, synthesize, and analyze information that will help us better understand public health problems and their solutions. So we may understand and communicate peer-reviewed public health literature for maintaining public health practice and introducing new practices. So we may succinctly articulate important statistical ideas and trends to colleagues and the general public. And very importantly, so we may develop tools to navigate misleading or incomplete public health information. Unfortunately, that's a thing. Data are everywhere, and it is not going away anytime soon. When I was studying statistics initially in the early 2010s, which was a time where the technological advancement, pales in comparison to what it is now, but it was starting to kind of take a shapeshift of its own. The amount of information that we have at our disposal is exuberant. We have so much information. There's so much data everywhere all the time. So becoming data-driven is more or less a standard of practice. And to not listen to data puts one in an antiquated professional status, regardless of what industry they are. So it is important for everyone, including us as public health professionals, to be data-driven. And what does it mean to be community-led? That was one of the pillars of today as well. To be community-led means that your efforts are not led by necessarily an organization or other outsider entities, but rather by the collective community for which you reside. As public health professionals, we want to be community-led so we may empower those in our community to participate in and feel a sense of ownership for their own development. Community-led means that you may foster sustainable and equitable growth and build resilience in your communities. And especially in rural health systems, we may utilize the limited resources we frequently have access to. It is no secret that rural health is generally under-resourced and remarked as a governing body. We are often left with trying to do several things at once. We're trying to allocate resources in a way that is always seems to stretch us really thin. In the United States, about 20% of the United States of the population resides in rural areas, but fewer than 10% of aggregate resources are allocated to rural areas. So just right off the bat, there's a disproportionate allocation. And that's not necessarily going away anytime soon. So to make things community-led means to be more methodical and efficacious with the allocation of the resources you have. We're going to go into examples down the road here when we talk about community health needs assessments and how to successfully be community-led. But I wanted to make that plug here at the start. So back to data-driven, which couples with the community-led aspect. To be data-driven, we must recognize the importance of the research question. What is it that we want to know? You have data, you might want to ask a question. You might want to explore something within the data. There's a navigation to establishing that question, and it's important. It is the pivotal point of figuring out what you're trying to do. Features of a good research question consider all of the following. It must be relevant. You must have a research question. You must be able to ask a question that your data are able to answer, something that is covered within the context of your data. It must be manageable. It must be something that is within scope, not too large, not too small, and something that is doable. We all have idealistic ways that we pose questions to what we want to investigate in the public health sector. But it's important to temper the expectation to what your information can provide you. It has to be specific. We can't be vague and haphazard with the questions that we pose, because we need to make pointed, specific questions that can help us guide in making actionable decisions into the community. Has to be clear, has to be simple. I'm a culprit. I sometimes get lost in the shuffle with my own inquiries, as many others do. But health department personnel, collaborators, policymakers, all must understand what you're hoping to find out. As public health professionals, clarity, concise, simple language is a very, very important asset to have. It's got to be interesting. We got to want to know what the question is. And it has to be legitimate. Has to be constructed as an actual question, not a statement, because it needs a measurable answer. We'll look at an example here in a moment. There are a lot of frameworks to help individuals conceptualize this across different areas of industry. In public health work, the FINER framework is often used, essentially a truncated version of these components. Is it feasible? Is it interesting? Is it novel? Is it ethical? Is it relevant? Oh, and a quick note, we'll make sure that these slides are circulated after today. And I have the hyperlinks for everything that I include. So clicking on this framework would give you this guide. So for all the references, all the data sources, all the studies, everything that I share today, there will be a reference for. So you can just click on it and access it through this slide deck if you so choose. So here's a few examples of good and bad research questions. Should abortion be legal? Is it right to have capital punishment? These are not empirically tested questions. They're subjective questions. Asking if abortion should be legal is not a scientific question. So you have to ask something that can be appropriately asked in the objective space. It can't be a general topic. Let's look at sexuality and aging. Let's look at treatment of alcohol and drug use. If you do that, you'll use your data in a very incomplete way. It's why we need to ask a question. If you just list a series of variables, what's capital punishment and racial discrimination? Let's look at that in the community. Well, what exactly are we going to look at? Do police affect delinquency? What can be done to prevent child abuse? These questions are a bit vague. They don't get after a specific component. Has the incidence of child abuse risen? How does poverty affect children? What problems do children who grow up in poverty experience that others do not? These are getting closer, but we need a little bit more meat. Good research questions, whether they're exploratory, descriptive, or explanatory, ask a pointed, measurable, specific, relevant question. Has the incidence of new forms of child abuse appeared in Wisconsin in the past 10 years? It's a good question, and it's an answerable one. Descriptive questions. Is child abuse more common in families that have experienced a divorce more than intact, never divorced families? That's a question that can be answered. Explanatory. Does the emotional instability created by experiencing divorce increase the chances that divorced parents will physically abuse their children? Again, it has all the necessary components to be an actual research question. When you have data, obviously looking at data is not, it's not like one needs to establish a research question before you even take a look at data. Frankly, looking at data should help inform the construction of research questions. But until you establish a research question, the exploration of data will be wanting. So as you navigate whatever information you have at your disposal, it's important to think of it in terms of an actual research question, and it'll strengthen the rigor that you do for your in your professional role. Now, to answer a research question, we use data. And there are two main approaches we take to collecting data. There is primary data and there is secondary data. Excuse me. Primary data are data that are collected by you directly. Secondary data are data that is collected by someone else earlier. By no means do you necessarily have to collect the information to answer a question, because there is a ton of information, as we already discussed, that is out there in the ether. Usable data that you can access and use to explore your research question. Now, traditionally, primary data, if you were to collect information yourself, tends to maximize accuracy and reliability. Because you are the one that's collecting the information, there's a greater buoyancy to making sure that you're asking everything that you want to ask in the population that you want to collect the information on. That's not to say that secondary data isn't accurate. You can find secondary data sources that serve your purpose, but generally secondary data is more beneficial for maximizing accessibility, because we don't always have the resources or the time to collect information ourselves. Sometimes that is a luxury. Oftentimes it is. So in public health, it is very common for us to use secondary data. And we'll get after a few examples here in a moment. But first, quick pause. If you all would be so kind as to provide an example of data you have recently worked with in your public health role. Could be any data. Could be electronic health records. Could be vital statistics. It could be death certificates. It could be claims data. It could be anything. But if you could provide me with the information of what those data are, and if those data are primary or secondary. Let's all take a moment to plug that in. I'll give everyone here 3 minutes. And as you're plugging that in, I will make a quick note that data are plural. So my language being that are data primary or secondary, what are data doing? That is grammatically correct. Had a conversation with a colleague the other day where we discussed that. So I just want to make that note to you all. Oh man, a lot of data here, guys. Love it. Okay, cool. We got key informant interviews. We got some qualitative data, primary, perfect. We got the infractions in ethnic restaurants. Interesting. Secondary data from Deb, cool. Youth risk behavioral survey, excellent. Number of people, some observational data looks like from a mobile support team, how many people were diverted from a jail, communicable disease data, test results. Oh man, this is awesome. I won't be able to get after every single response, but this is why I have to follow up with you all after this. Just because sometimes there's too much to go through in a 2-hour frame. This is good stuff, guys. Thank you. Components of a CHA. Okay. Oh man. Ooh, someone has Casper data, suicide data, vaccine. Oh, all right. Cool. Thank you all. The data that you provide here, I'm going to ask another question about it here a little later on. So make sure you have that in your pocket. So again, primary data collected by you directly. This is information that you pool. This can be done by surveying a group of participants in your community, like a community health needs assessment. Community health needs assessment that you conduct is primary data. Collecting observational data, a handful of you gave examples of that. Conducting interviews or focus groups, the data can be qualitative. It could be records of having conversations with people. That's data as well, and that's primary because you collect it yourself. I imagine that everyone who indicated that they have a primary data source did so to try to get after exactly what they were trying to collect in their community, making it an accurate data source. And then secondary data, a lot of you gave examples of that, data collected by someone else, the Youth Risk Behavioral Survey. That's something done at the state level or the federal level. Montana DPHHS, there's a lot of data sources that come through the pipe at the state level. There's the vital statistics, the death records, suicide data, also secondary. Behavioral risk factor surveillance system, that one's been used quite heavily. Secondary data sources. US Census, EHR, all stuff that is collected, that would be collected no matter what, and then you can use it for your own exploration. Thank you all for sharing. If it isn't already abundantly clear, we use secondary data a lot in public health, so often. And there are a lot of information that you can use at your disposal. So I know a lot of you probably already know some of this information, but I want to make it abundantly clear that there is information out there that is publicly available at no cost. And as long as you have a broadband internet connection, you can ascertain this information seamlessly in moments. So I have just a few examples to highlight. The census. The census is a treasure trove of data. Every 10 years, the census collects information on the population of the United States, the general population. There's a lot of demographic, geographic, and housing characteristics that are ascertained. This is just one of many examples. Here I collected the annual estimates of the resident population for counties in Montana from 2020 to 2022. They had the actual results pulled on April 1st, 2020, which was the time that they reported, I'm guessing, the 2020 census data. And then based on a myriad of information that the census has at their disposal, they provide estimates. And here is raw data that can be downloaded online off that link below, for instance, where you can get an up-to-date, year-specific or yearly estimate of the population of your county. So just one example. Do you need estimates for poverty, unemployment, or educational attainment, for instance? Data are available. The USDA, the Department of Agriculture, another federal governing body, has downloadable data at your disposal. Here I pulled poverty estimates for US states and counties from 2021, it looks like. So again, a free data source that you can use at your leisure. Now, oftentimes, I do want to make a note that for a lot of usually very dense data that is accessible online, you'll see information in pretty large Excel files. So here we see, obviously the rows indicate a state and then all the counties in that state. So there's thousands of lines because there's, I think, almost 4,000, 4 to 5,000 counties across the country. Can't remember the exact number, but anyway, there's several thousand lines of data in this data set. And as we can see to the left or across the row, there's unique data titles. Obviously, everything is structured in a very concise and organized way, but make sure that you refer to the variable descriptions that are always included in these large data sets. So down below, where you see the raw data, there is also a sheet that indicates the specific variable descriptions. Just an important note to navigate these large data, so you know exactly what you're referring to when you use the information. Do you need Montana-specific health data and reports? Again, data are available. DPHHS sits on an abundance of data sources that can be used for you in your professional roles. That's by design that's one of the primary functions of them. These are screenshots of the interactive dashboard on the DPHHS website. They have a lot of administrative data like birth and death records, childcare, vital statistics. They have behavioral risk factor tracking with the behavioral risk factor surveillance system, the youth risk behavioral survey. They have chronic disease, communicable disease, community health data, epi data, and that's just the list goes on. And then to the right, there is a screenshot of the first page of the report for the Montana Vital Statistics. This is a report that aggregates a lot of the information that you might be interested in. For example, on this first page, there are age-adjusted death rates for Montana compared to US residents from about the last decade, showing that the increase is comparable, Montana compared to the rest of the state. It's this information that is useful for not just for your own data inquiries, but sometimes if you want to make an argument or establish evidence around another topic that you're curious about. It's always good to use the information that is currently available to you. Now, I want to make a quick note that DPHHS, and several of you indicated that you are using current DPHHS data. Fantastic. I have used a lot of DPHHS data in the past. And I do want to make one note that oftentimes there may be instances where you need to submit a data request to obtain the information you're looking for. This data request is not cumbersome. It just requires a little bit of fine tuning, because if you're asking for specific raw data from the state, you need to make it clear as to exactly what information you are looking to collect. I have an example here to highlight here in a moment. This data request is of no cost, and there are health administrators, epidemiologists at the state health department that provide assistance in this oversight. So just to make a note, sometimes you might have to actually coordinate, which is fine. It's actually helpful to do that. Sometimes it actually helps you kind of figure out what exactly you're looking for too. So here's a couple examples of public health work using secondary data. This is a study that I did when I was in my doctoral program. The research question was, is there an association between mental health challenges and a usual source of care among US adults? So I was curious to ask a research question in the overarching population of the country. And fortunately, there are federal or national surveys that collect information on these things, on mental health, on barriers to care, on usual source of care. The National Health Interview Survey is a principal source of the information on the health of the civilian non-institutionalized adult population of the US. It's an in-person survey administered annually to about 35,000 households across the US. It records a lot of health, disability information. And then the way the survey is done is they'll take a random adult within each household and then ask them more pointed questions about their mental health and healthcare access. This data source was publicly available at no cost for me to do this study, because I wanted to look at the association between mental health and having a usual source of care. I've used this study as an example also to show that if you use secondary data, there's oftentimes explanations to inform how representative the sample is. So if you're trying to get a sample of people all across Montana or all across the country, then usually having something at the state or federal level from DPHHS or the CDC, respectively, they do the due diligence to make sure that whatever data you're collecting can be generalized to whatever populations that you're trying to make decisions on. This is another example of public health work using multiple sources of data. Sometimes we need to collect information across a myriad of sources. For this study, I was looking at the association between the density of healthcare providers per capita and suicide across Montana counties. I had to do a little bit of legwork to find the information for this, but again, it was all available at no, actually this one had a very, very modest cost because I used the WIM tracking system for those of you familiar. This is a health workforce database that manages the current professional and geographic status of healthcare providers in Wyoming, Idaho, and Montana. I was initially planning to use the National Provider Identifier Registry, which is publicly available at no cost, but there's some limitations with the NPI registry. Things are not always as up to date as they otherwise should be. So instead, I use this new nuanced system, which had a very, very minimal cost to using it. But I did that, and I collected secondary data from the Office of Vital Statistics at DPHHS because I needed to collect the suicide data. One of you indicated that you're using suicide data. Perhaps we collected it from the same source. This is the information that you would present to DPHHS if you wanted specific information. So I said that mortality data were obtained by the following request. I requested National Center for Health Statistics list cause of death, injury, intentional self-harm, and there's a series of ICD codes that fit that inclusion. I wanted all counties across the state. I wanted the suicide cases that were registered from years 2003 to 2019, all sexes, all race and ethnic populations, and all age. So this is the information that you would send to DPHHS. There is coordination to navigate the specs around that. So there's always resources and individuals to help you kind of navigate your own data needs. And then I got the raw data, and then I used that for this study. So these figures to the right show a county level examination of suicide and the density of healthcare providers. Those bubbles, the larger bubble indicates more providers per capita in a region, and then the darker shades of green indicate areas of higher suicide. I also broke it down at the regional level, finding that Region 1 has both fewer providers per capita and an elevated suicide rate as compared to the rest of the state. So data, secondary data that's publicly available, specifically data from the state, was used to do something like this. So if you were interested in examining something similar to this construct, the information is available. There were a few folks that indicated that they wanted to learn more about health initiatives and the current status, the current landscape of our public health infrastructure across the country. So I like to make a note to kind of inform people on the Healthy People 2030 goals, because these reports are also publicly available and also very useful for establishing the evidence around your work in your public health roles. So for those of you unfamiliar, the Healthy People Initiative helps individuals, organizations, and communities committed to improving health and well-being to address public health priorities. They're done through 10-year national objectives. It was originally created by OASH, the Office of Disease Prevention and Health Promotion at the U.S. Department of Health and Human Services. Healthy People helps identify areas and populations with the greatest need to focus on their resources and efforts accordingly by setting their own priorities. Healthy People provides data, another public data source. that you can use to illustrate national progress towards achieving objectives, evidence-based resources to help with program policy development, and tools to inspire action, encourage collaboration, and empower the initiative. At the start of every decade, the Healthy People objectives are re-established. This started back in 1979 when the Surgeon General issued a landmark report. A year later in 1980, the Healthy People 1990 was released, so they're 10-year objectives. In Healthy People 1990, it included the first set of ambitious, measurable objectives. At that point, it focused on decreasing deaths throughout the lifespan and on increasing independence among older adults. Healthy People 2000 was the second iteration to increase the span of healthy life, reduce health disparities, and achieve access to prevention services for all. In 2010, had an increased focus on improving quality of life and to eliminate health disparities rather than just reducing them. Healthy People 2020 started to expand outward with these objectives to obtain high quality, longer lives free of preventable disease, disability, injury, and premature death, to achieve health equity, eliminate disparities, and improve the health of all groups, create social and physical environments that promote good health for all, and promote quality of life, healthy development, and healthy behaviors across all life stages. The most recent, Healthy People 2030, that was launched back in August 2020, builds on the knowledge gained across all these decades. Now, the focus is around equity, social determinants of health, health literacy, and a new focus on well-being. You can see from these objectives over time that our public health capacity has grown. Initially, we're trying to just reduce, we're trying to increase life expectancy. But as we kind of evolve in the Healthy People Initiative, we realize that there's more to quality than just life expectancy. There's disability, there's injury, disease, there's health equity, social determinants of health, all these components. So Healthy People Initiative has been an ever evolving kind of characteristic of our lives. And every one of us in our public health roles are standing on the heels, or standing on the shoulders of all the public health work that has been done up to this point. So we are now a resource that is continuing to move the line forward in these new initiatives. There are certain indicators that show that this has been working over time, especially from the inception of the Healthy People Initiative. This figure shows that the life expectancy from 1970 to 2010 has increased over time for all racial groups. However, I know that more recently, life expectancy, for instance, has taken a slight decline. So this isn't the most timely, just kind of emphasizing the historical reference of the Healthy People goals. As noted before, Healthy People goals are publicly available. There are a ton of unique objectives that are set on the national stage. This is one screenshot that collects the information on the objective to reduce the proportion of people who had opioid use disorder in the past year. Again, publicly available online, and this kind of does a good user-friendly illustration to show how well the objectives are being met. Sometimes they're indicated as improving, or perhaps there's little to no detectable change. Maybe they're in the developmental stage. Maybe there is no improvement at all. But essentially, you can use information from the Healthy People Initiative to use as a landmark to establish the rationale or perhaps the direction of your own research questions. For instance, we're not doing well nationally about vaccinations. Here's the evidence. You pull the evidence off of the Healthy People 2030 goals. You reference the fact that this objective is not being sufficiently met in the last year. Therefore, XYZ. it's all information and data that is intended to substantiate the work that you're doing. Okay, so now we're going to pivot to different ways to use data. When we say different ways to use data, we're generally referring to study design. And a study design is a set of methods and procedures used to collect and analyze data in a study. So when you establish a research question, then you figure out what your actual design is to investigate the research question. There are descriptive and analytic studies. I will not spend too much time here, but I want to share with you all examples of different kinds of studies and the different kinds of questions that can be done in the context of those questions, just so you all have a sense of the variability across ways that you can explore data. There are descriptive studies that describe characteristics of a population of interest. Here, you're not necessarily measuring a yes/no response, but you're asking still a question to get a sense of characteristics in a population. Generally, these are done with either case reports or case series, a case series, which again, just take a deep dive into either an individual or a subset of a population. And they look at some sort of phenomenon or similar experience. Great example of this here is a clinical presentation of COVID-19. This was done by a group of researchers in a public health department over in Italy, done at the height of the pandemic. It was published in June of 2020. At that point, we did not know all that much about the coronavirus pandemic. Y'all remember back to those dark days. There was a lot of ambiguity. There was a lot of confusion around navigation, prevention, etc. So this study took 40 patients who came in and had a positive test of coronavirus. And this just simply describes their demographic, clinical makeup, just to understand who they are. They looked at the age of the patients, if they have any coexisting medical conditions, if they have any other characteristics of note. So this is an example of using data to describe some sort of phenomenon. In this case, it was the coronavirus. Perhaps the most famous example of a case series is the example from the father of modern epidemiology, John Snow. I'm sure many of you have been informed of are familiar with this story, with this study. Back in 1854, there was a physician who was working out of London who noticed that there was a giant cholera outbreak in it was in Soho, one of the most populated urban centers in the city. And at the time, London was like the center of the world, so it was the staple of the innovation and direction of the world. And there were an erroneous number of deaths that just came about by cholera. This individual, John Snow, tracked cases of cholera and found that there was a water pump in the West End district, on Broad Street, that was clustered around a lot of the cases of death. So they tracked where the individuals lived and found that many of them were in the vicinity of this pump. Now, this was before epidemiological investigation and public health really had, a purpose in the world. There were no healthy people 1850 objectives, for instance. That has only come much later. But this was the inception of it, really, because this guy, John Snow, identified, hey, there's a lot of deaths around this pump. Let's shut off the pump. No one, and it was scoffed at. No one thought that was it. People thought it was the weather or the smog in the city. But they turned off the pump, and they turned it off right at a couple weeks after the outbreak took off, and then the incidence of death took a drastic decline and ultimately stopped shortly thereafter. A case series, simply looking at data. This individual just took information and tracked it. This also was an initial mark of geographic information systems research, using visual data to characterize a research question. Those are descriptive. There's also several analytic studies that often look at a relationship between one variable and an outcome. Traditionally, these are observational studies, particularly in public health work, where outcomes are observed. There's no manipulation of the subjects. It's one of the staples of our role in public health. Oftentimes we do not interfere, or shouldn't say the word interfere. We often don't manipulate characteristics of the population. We often observe things and then report back. The first is a cross-sectional study, which involves looking at data from a population at one specific point in time. The advantages to this are that it's very quick and inexpensive and easy to conduct without any ethical challenges. However, you cannot make a causal inference. If you're looking at a snapshot in time and there's no measure of time in your data, you cannot determine which event came first. You cannot establish temporality between an exposure and outcome. You can only rather say that the two characteristics are associated. So in the study that I mentioned before, when I found that there was an association between mental health challenges and not having a usual source of care, I can't necessarily claim from this study that a person's mental health caused or led to a person not being able to have a usual source of care, or vice versa. There's another study I have here from my colleagues at the University of Montana that looked at nurses' perceptions, experiences, and practices regarding the HPV vaccination. And these were results from a cross-sectional survey in Montana. Quick note, which study collected primary data and which collected secondary data? Does anybody know which study has primary, which study? Nurses primary, beautiful. Thank you kindly. This one on the left was primary data because these individuals pilot tested an online survey to look at nurses and medical assistants and their perceptions and experiences around the vaccination. This was something that they administered out and collected the information on. Whereas my study, I used data from the National Health Interview Survey. That was information that was already there, and then I just reached and grabbed it. Beautiful. Okay. We also have cohort studies. Cohort studies look at data that follow participants longitudinally over a period of time. They can either be prospective or retrospective. You can either look back in time or forward in time. These are particularly helpful because they are robust measures of establishing cause and effect. Because you look at things over time, you can determine a temporal relationship. You can see if something led to something else occurring. However, the disadvantages are that you might have to follow people for long periods of time. It could be potentially very expensive and time consuming as a result, because cohorts are not something that you can collect as easily as a cross-sectional survey. The examples I shared before were cross-sectional in that they were at one point in time. Cohorts are over a period of time. And perhaps the most famous cohort is the Framingham Heart Study, for those of you familiar. The Framingham Heart Study began in the 1940s, and it was designed to track health information on men and women who originally did not show signs of heart disease, but then they followed them over their entire life, as well as the children of those participants through their entire life. It's still running currently to date, so it's the most comprehensive cohort in modern history. And it essentially tracks information on different health challenges and health outcomes over time. And obviously, this study is incredible, but very timely and expensive. And then we have case control studies. Case control studies look at data by comparing two groups, one group with an exposure or disease and another group without that exposure or disease. The advantages are that you can study rare diseases or outcomes with a long latency period. However, you might have certain issues with bias. An example of this, another one at the heels of the COVID pandemic. This was a case control study done out of Portugal from a health department there. This was looking at individuals who are health professionals versus not health professionals to see if either group had a higher prevalence of having a positive COVID diagnosis. So they took individuals who were both tested positive for COVID and people who tested negative, and then they looked to see if what was their profession. Were they a health professional or a non-health professional? And they found that in this population, which was based on national surveillance data, that the percentage of individuals who had a positive COVID or a positive COVID screen was higher among health professionals. Just showing how different data are used in different contexts. There's also experimental studies, which are usually randomized, the term RCT, where you essentially you manipulate the data by giving one group a certain intervention and then a control group by getting a different intervention or nothing at all. And then you would then study what happens to people in each group. The advantages of this are that you're controlling for everything, so you can determine causality pretty well, and it can be combined with other research methods, but there's human error, it can be time consuming, and there may be ethical challenges here. In terms of public health, we often reside in epidemiological studies that are descriptive or observational by nature. Experimental studies are not something that are traditionally practiced in public health work. That's not to say that they never are. I don't want to speak in absolutes, but most of the time our work will be observational in nature. So another quick pause here. Think back to the data example you mentioned earlier. If you were to conduct a study with those data, what research question might you be able to explore? And what kind of study would you conduct in exploring that research question? Please take a few minutes to put that plug in the chat. So you all have youth risk behavioral survey data, you have surveillance data, you have suicide data, you have test results, you have all these different things. What question could you ask? What question could the data possibly answer for you? How many individuals were diverted from the justice system after interacting with a mobile response team? Love it. Stephanie, fantastic. Do ethnic restaurants have a higher incidence of priority foundation infractions? Okay. Deb, love it. How many individuals suffering homelessness suffer mental health? Interesting. Thank you, Raven. That'll be interesting. You take a group of homeless folks, mental health screening. Oh, yes. The key informed interviews, exploring thoughts, feelings, perceptions. Feelings, perceptions about what? Oh. Using the Youth Risk Behavioral Survey, I would ask if the incidence of drug use is related to mental health. Awesome. it's interesting. The YRBS is, if you collect information at one point in time, it would be a cross-sectional study. But if you looked at a trend over 10, 20 years, then you're dealing with a cohort. So you could do different study designs based on the information you collect. There's always bountiful opportunities that come through the pipe, especially with aggregate sources of data like that. Beautiful. Thank you all for sharing. So we've heard a lot of like different studies will be stronger or weaker. Like the RCT is like at the top of the list. And I want to just make a quick plug to the public health workforce in Montana that the strengths and weaknesses of a study design should be seen in light of the kind of question that the study is set out to answer. Sometimes an observational study is the only way a researcher can explore a research question. Sometimes you can't do a randomized trial. For example, it would be unethical to design a randomized control trial deliberately exposing workers to a potentially harmful situation. If a health problem is a rare condition, then you can do a case control study and look at individuals who both exhibited the outcome and didn't, and then look back in time. Or if you want to explore a population that you feel is at risk of a certain outcome, you can look at that in a cohort and observe the results there. So as long as you think critically about your research question, there's always a way to explore it. And I do want to make one note before we take a short break here of causal inference in observational studies. How do we establish, for example, that smoking causes lung cancer? That is now a well-known facet of our work and the public health landscape in modern day. But it wasn't always that way. A strong case for cause and effect can still be made, but it always takes work. There's a lot of legwork that comes into play to establish sufficient cause and effect that then generates policy. The conclusion from the US Surgeon General in 1964 that smoking causes lung cancer was based on a number of factors, a number of studies, a number of different ways that data were used over decades of work. Studies looked at the consistency of the association across different studies to look at smoking and lung cancer. They looked at things both retrospectively and prospectively, back in time, forward in time. They measured how strong the two were, how closely smoking is connected to lung cancer. They looked at the existence of a dose response. They looked at people who smoke a pack a day versus people who smoke a cigarette a day, for instance, and look to see if there were changes that came about in their propensity for lung cancer. They made sure that they established temporality. They did experiments in animals. They established the plausibility based on the biochemical components of what happens when you smoke. And all of that collectively helped establish a strong case for cause and effect. But it can't be done by itself. So causality and making actionable decisions for the purpose of policy change, especially in public health work, is erroneously challenging. One of the first papers I wrote or read in my program at UM was both very discouraging and humbling at the same time. It said the best public health work you can do is work that will likely never be fully achieved in your lifetime. So that kind of puts things into perspective in terms of what our role is in public health. But it's all a building block. So I want to take a 10-minute break here, and then we'll do the back half of the presentation. In the meantime, anyone who's given any thought to this question, I think about it quite often. If you had all the time, money, and resources at your disposal, what research question would you like to explore? We will resume at 10:15. Not a break to bring us back into the fold. I love these research questions many of you have put in the chat. The overall financial ramifications caused by health inequities of minorities. To do a natural experiment to provide universal income and assess whether and how health inequalities, mental health, substance abuse, or use of health services reduce. To look at what makes people feel connected, to do a global study across all types of people, all types of backgrounds. That would be amazing. To do something similar to Emily's, providing universal health care to every person, assess the measures of overall quality of life, reports of positive or negative emotion, depressive symptoms, suicide, homicidal ideation. Love it. Love it. I have very idealistic research questions I like to pose in my day-to-day in my work, and sometimes it's fun to see what can be done. I like to also kind of think through that, because sometimes it even informs the direction of my of the work on the ground that I'm currently doing. So thank you all for sharing. Very much appreciated. Okay, so now we're going to get after community health needs assessments. I'm super excited to get after this. So first off, let's just talk about what it is. A community health needs assessment refers to a state, tribal, local, or territorial health assessment that identifies key health needs and issues through systematic, comprehensive data collection and analysis. This is done with a multi-sector collaboration that involves shared ownership of all phases of community health improvement, including the assessment, the plan, the investment, implementation, and the evaluation. It's often done proactively to a broad and diverse community engagements. A definition of community that encompasses both a significant enough area to allow for a population-wide intervention and measurable results. There's maximum transparency to improve community engagement and accountability. A use of evidence-based interventions and encouragement of innovative practices. An evaluation is a must to inform the continuous improvement process. So, and the use of high-quality data pooled, so from diverse public and private sources. Community health needs assessments comprise this very holistic examination of the needs of a community. We are going to look at how it's done based on guidelines from the CDC and what has been successfully done in Montana in the last year. So the CDC created this rapid response called the Community Assessment for Public Health Emergency Response, called a CASPR. So it's a type of rapid community needs assessment that provides household level information to public health leaders and emergency managers. It's an adaptation of epidemiological techniques used by scientists from the World Health Organization's expanded program on immunization to estimate vaccine coverage in Africa. This was done years ago. The information generated can be used to initiate public health action, identify information gaps, facilitate disaster planning, response and recovery, get resources, or assess new or changing needs in the community. So the CDC created a toolkit that is also publicly available to outline their standardized methodology, to outline and standardize their methodology that you can use. It's fairly quick, inexpensive, flexible, can be used in either a disaster or non-disaster setting, and they can be used to influence public health in a number of ways. You can assess public health perceptions, estimate needs in a community, assist in planning for emergency response. It can be done as part of the public health accreditation process, which I know is a requirement, or rather a guideline attached to many of your roles in your county health roles. To monitor changes in community needs, to raise visibility of emergency management, to justify requests for outside assistance or funding, to evaluate the effectiveness of response activities, and to serve as a field exercise to build for disaster preparedness. There have been a lot of CASPRs done over the last 20 years in the US that have done assessments based on these criteria, based on these guidelines set up by the CDC. They've been done all over the country. Here in Montana, we have done 6, or there have been 6 done in Montana that have used this rapid needs assessment guidelines from the CDC. But there are specific examples where a CASPR has been particularly helpful. Back in 2008, there was some severe flooding in Linn and Johnson County in Iowa. They did a CASPR. For those of you who remember those hurricanes on the East Coast back about 10 years ago, Hurricane Sandy decimated Suffolk County, one of the suburbs in New York. They did a CASPR as well. Addressing California drought in Mariposa County in 2015, a CASPR was done for that to examine the ongoing effects of the drought. Back in 2015, there was also this giant oil spill at the Navajo Nation in Colorado, the Gold King mine. CASPR was done for that. And in 2016, the Zika virus appeared in Williamson County in Texas, and a CASPR was done to examine that. All interesting environmental and or epidemiological health challenges that can take the form of having a rapid needs assessment. In Montana, Hill County, Madison County, Mineral County, Valley County, Richland County, and Dawson County in the last decade have all done their own community health needs assessment with the context of the CDC guidelines that are illustrated here. So, been all over the show. When you're considering a CASPR, there are characteristics attached to considering the sample methodology. I won't go too into this. I don't want to get too deep into the weeds here, but I have this information provided in if you would like to use the CASPR guidelines set up by the CDC. They have an online system to provide context. They have training resources for disaster epidemiology training. I will purposefully not get too deep here, but all the information is available if you would like to investigate further, as well as their phases. Their phases are to prepare for the CASPR, to conduct the CASPR, to analyze and report the CASPR. The first phase being to work with the leadership and stakeholders within your state to plan and prepare, to actually conduct the CASPR, to do face-to-face interviews, to collect data, and to have interview teams, to analyze and report the CASPR data, the ascertainment of the records, to then put into usable data files. I won't get too deep into the weeds here because I'm about to show you an example of doing this in real time, comparable to the scientific rigor of the CDC, but with specific to Montana resources and functionality. So that leads me to sharing with you something that me and my team are extremely proud of, and we believe that there has been a unique means of success achieved in Carbon County in the last couple of years. We have published a needs assessment ourselves, and I will share it with you here. So for those of you familiar or unfamiliar, Carbon County is south of Yellowstone County. Has about a population of about 11,000. It's located south central Montana on the eastern and northeastern end of Yellowstone. Red Lodge is the county seat, largest city, and it comprises much of the Absaroka and Beartooth Wilderness. Carbon County has kind of been at the forefront of a lot of overlapping environmental disasters of late. In 2021, there was some pretty horrific wildfires. That's not unique to Carbon County. I want to make that very clear. Wildfires have been having a lasting and extreme impact on our landscape for years now. it was interesting how things were coupled with severe flooding in the following year. For those of you who recall, in the news in June of 2022, floods were pretty much decimated, like Red Lodge and the surrounding areas. So I actually met with the Carbon County Health Department Director, Erin Cross. She attended the 2022 Summer Institute, the Montana Public Health Training Center, at that time. So she essentially, in this very workshop training, we convened, and Erin expressed Carbon County's interest in conducting a community health needs assessment that represent areas and populations of the county that have not been captured in previous assessments. The hard to reach populations. These were the specific components that she was interested in doing for the purpose of a needs assessment. Everyone has different things that they're necessarily trying to ascertain when doing an assessment. It's always important to consider those things up front. My team and I employed a 4-stage approach. This approach, the stage 1, 2, 3, 4, is comparable to the stages you just saw as illustrated by the Casper. The first stage, which we completed in December of 2022, was community information consolidation. We followed that up a month later with the development of the needs assessment. And then in the springtime, when it got a little bit warmer, we did the implementation of the assessment. And then in the months thereafter, we evaluated and presented the needs assessment. Stage 1, community information consolidation. The primary objective of this was to consolidate all up-to-date information on the residents of Carbon County to identify gaps of interest. This stage is always a must. If you all are going to be doing any form of any assessment or any examination of the like, use the information that you have at your disposal. Earlier, we looked at a ton of different resources that you have at the state and federal level to glean information on the health composition, on the demographic and housing characteristics of even things at the county level, even like characteristics at the county level. There's always information that you can use to not start from scratch. And to be data-driven, you want to do this. You want to use the information that has been pooled to date, because there's usually a good amount of it. It's local, state, and federal. Population level estimates, previous needs assessments, questionnaires for another topic, from another organization, interview records are just an example of such. So our consolidation of information comprised 4 unique sources of data, and each of them painted a nice picture of the puzzle to help us kind of conceptualize what it is we're dealing with in Carbon County. The first was obviously taking data from the U.S. Census. We collected demographic and housing characteristics to get aggregate measures of the population. Then we had 3 assessments that were actually done over this time. There was the in 2022, the year before, the Beartooth Billings Clinic conducted their own community health needs assessment in-house. So we used the record from that. In 2022, the Community Assessment Survey for Older Adults was implemented statewide. This was done by Area 2 Aging. So it was an aggregate assessment across the entire state, looking at the health needs and challenges of individuals aged 55 and older. And then the Red Lodge Area Community Foundation, a nonprofit organization in Red Lodge, had conducted their own housing assessments. So we pulled information from all of these sources to make sure that our approach is data-driven. We don't want to start from scratch, and we don't want to reinvent the wheel. We want to use the information at our disposal to inform the needs assessment we want to do. And collectively, the key takeaways from these data sources were that residents of Carbon County have notable concerns when it comes to affordable housing, cost of living, availability of healthcare, and access to mental health care. There's a lot more that has been comprised into that. And I have attached the full report that we have collectively here for your reference. So I guess if you already have information on housing, on older adults, there was already a needs assessment done. Why would we do another one? Why do we need to do a needs assessment? Well, none of these assessments were done across the greater Carbon County community in the population that the Carbon County Health Department is trying to reach, because there are likely many residents who who were not represented in any of these surveys. We're also interested in other health needs and challenges, not just ones that are specific to a clinical needs assessment or an older population or housing specific characteristics. We want to know health indicators. We want to know people's perceptions of the flooding. We want to know people's perceptions of the coronavirus pandemic. We want to know people's access measures. There were all these additional things that we wanted to know about and that weren't necessarily captured in these. So it's helpful though to be able to pool the resources you have and then realize what you're still lacking, what you still want to know more information about. So after that, we then started to develop the needs assessments. In this stage, we gathered information that we collected in stage 1 and coupled it with key informant interviews. This was done to triangulate information represented in the county, both from a systematic and individual stance. The key informant interviews were done in a qualitative, in-depth interviews with people who know what's going on in the community and present unique perspectives. So we had Zoom meetings with 3 individuals in the community: a library director at the Red Lodge Carnegie Library, a disaster recovery navigator with the Red Lodge Area Community Foundation, and a fitness instructor and community advocate in the area. These residents represented various locations within the county and were able to provide a diverse range of experiences and concerns. The interviews helped further inform both the quantitative and qualitative items that we included in the subsequent survey. This is also the piece that makes it community-led. I live in Billings, and I'm not from Montana. I'm from New Jersey. I should never infer anything about Red Lodge or anything that I'm not fully aware of myself. Oftentimes in research or in general, we don't want to. It's important to not make over assumptions of community needs and challenges. So community-led is the way to go. Talk to the folks who have a better sense of the human experience in communities than you do. The survey was created using a variety of sources. Some of the items were taken directly from the Community Health Needs Assessment conducted by the Beartooth Billings Clinic, and others were incorporated the feedback from the key informant interviews to find validated measures of the specific concerns that we measured, particularly availability of resources, transportation, affordability, etc. And then from the interviews, it became apparent that the coronavirus pandemic, and the flooding remained large concerns. So we included qualitative questions to glean information on those. So we created our surveys in accordance with all of that collective information. Then we implemented the needs assessments. The objective was to conduct and collect all the data. We utilized a number of recruitment techniques to ensure that our sample was as representative as possible of the nearly 11,000 folks in Carbon County. We posted the online link of the survey to social media recruited, posting the online survey link got almost half of our survey respondents. Use social media, guys. It's not going away anytime soon, and it is a great way to reach. We had a QR code available for the online link. The Carbon County Health Department also engaged in tabling at various locations across the county. We went to not just Red Lodge, not just the county seat where most of the folks are. We went out to Bridger and Joliet and Roberts. We spent 2 days in the field where we were standing outside of grocery stores and community centers, senior centers, post offices, bars, I was posted up outside, inside the Joliet Library, and was able to connect with a few folks there. Being engaged in the community increases positive perception of the work you're doing and helps instill a more positive affiliation between the community and a health department. We found that these manual efforts were particularly fruitful when it came to the information that we collected, both in terms of quantity and quality. Residents also were given the option to complete the survey on paper and provide a stamped envelope and to mail it back into the health department. Not everyone uses a smartphone and a fancy QR code. We want to meet people where they're at. We want to make it as accessible to people as possible to fill out the survey. If you provide multiple modalities to collect the information that you need, you're gonna find more success. And the mailed surveys were successful. We got almost 15 to 20% of the responses we got were from those mailed surveys. We also utilized ads with the local newspaper. Announcements were made at the local television stations, the radio stations. And in total, we ended up getting 323 responses. Now, many of you might say, there's 11,000 people in the entire county. 323 is not that many. Yes, you're right. We are never able to collect information on an entire population. But those 323 people were super valuable to get because they comprised a unique composition of the population of the county. When we were evaluating presenting the needs assessment, which combined organizing the data, conducting the analyses, doing some tabulations across different domains of interest, we were able to observe unique comparisons of people in Red Lodge versus outside of Red Lodge, people at different levels of sex and education and geographic location. We were able to do more rich data because we were able to get a wider description of people across the county. A quick oversight of the results. We got folks around mean age of 57. Most were female, most were white, most were married, most were homeowners. Small majority had a college degree. Most had children. About 20% reported a disability. About 6% were veterans. And this is the main piece. These pieces are the big flex points to doing as much community-led outreach as possible. We ended up getting 323 respondents, and almost 40% of them were outside of Red Lodge. Oftentimes when assessments are done, there might be a disproportionate allocation of resources to the most densely populated areas. Red Lodge is the city comparison to the entire county as the county seat. But us going into the community helped us get a reasonable amount of responses across all of the small pockets of the unincorporated communities in the smaller towns across the county. And further, we found that the Carbon County Needs Assessment, the Community Health Needs Assessment that we had conducted, actually had a new reach over half of the folks who responded to it. So we asked on our survey if participants had completed the Beartooth Billings Clinic Needs Assessment from the year prior, the Community Assessment for Older Adults the year prior, and or the Housing Assessment from the Red Lodge Area Community Foundation. And 155 out of the 323 people that we got responses on, that's almost half, did not fill out any of those other assessments. So we had a new reach in the community that comprised almost half of our respondents. That is a success when it comes to doing a community health needs assessment, when you're trying to get a glimpse in terms of the overall population of the county. Obviously, there are limitations to this, but I want to make it, I want to emphasize that this is something that the Carbon County Health Department is extremely excited by. And then the analysis. I won't get too deep in the weeds. We did a lot of analysis. There was a lot of information we collected. The main points I could show you here. So in the top left, this is a cross tabulation to look at severity of people's uh, health measures in terms of how strong they have availability of resources. So there were some composite measures taken. I won't get too deep into the weeds because this is not a statistics talk. This is a introduction to data talk. But it showed that people at higher levels of availability generally have better overall outcomes when it comes to their health. For instance, 94% of individuals with poor overall availability of resources have moderate or high stress. Among the people with fair availability of services, so a little bit less encumbered by getting access to services they need, 85% of those people have moderate or high stress. And then if people have really good or excellent availability of resources, then only 65% of those individuals have moderate or high stress. Stress is a very fascinating characteristic to measure in public health because everyone's stressed. The world is inherently challenging and frustrating and stressful. So stress is going to be prevalent in any community you look at. But it's interesting for us to see that a person's level of availability of resources has a relationship with stress. We also found that mental health had a unique kind of association similar. So for instance, so on the bottom right there, we see stack charts to show the distribution of mental health at different levels of substance abuse. And we found that if mental health is worse, individuals are more likely to also have challenges that pertain to substance abuse, stress, loneliness, etc. Not something that is completely out of the realm of what we would conceptualize, but the fact that we have data to back it up in the community, in as generalizable of the community that has ever been achieved before. It's informative. It's helpful for a needs assessment. And then the qualitative responses. We asked open-ended questions to ask about people's top public health concerns, their perceived impacts on COVID, impacts of the June 2022 flooding. And residents reported their concerns primarily around increased cost of living, mental health, and affordability of healthcare, consistent with what we gleaned before. As the first community health needs assessment conducted since COVID began in late 2019, the impacts of COVID on the Carbon County community were significant. When asked, in what ways do you feel COVID continues to impact the community of Carbon County, some residents indicated that they continued to struggle with COVID. Some respondents reported feeling mental or emotional exhaustion, loneliness and isolation, or a lack of support. Many responses with the flood tied to individuals feeling financially ruined and displaced. However, there was positive regard with the efforts that were conducted by the health departments. This is a word cloud that we constructed in the shape of Carbon County to help visualize the qualitative responses. This can be a powerful tool to use. Overall, access to affordable housing, access to affordable healthcare, and mental health were the key concerns that we collected from the assessment. The Community Health Improvement Plan is what you do after a community health needs assessment. It is a long-term systematic effort to address public health problems based on the results of a needs assessment, typically a 3 to 5 year plan. The plan is used by health and other governmental, education, and human service agencies in collaboration with community partners to set priorities, coordinate, and target resources. It is critical for developing policies and defining actions to target efforts that promote health. It should define the vision for the health of the community through a collaborative process and should address the gamut of strengths, weaknesses, and challenges that exist in the community. It's important to do a community health needs assessment followed by a CHIP because the community health needs assessment informs the CHIP. The benefits are boundless in terms of strength of partnerships, identifying the strengths and weaknesses, the benchmark for public health practices, etc. There are 6 primary steps to do a CHIP. After doing the needs assessment, you then recruit community members. Successful community coalitions have diverse memberships, a clear-eyed focus on the goals and stable resources. You want to consider individuals who have a vested interest in the health of the community. Then the objective is to establish a shared vision. The health department and the team members must have consensus on this vision, and it should define the reasons for implementing the CHIP in the first place. There is no limit to how many priorities you can set, but generally you want to be specific and focus on the top health issues of the community. The key concerns that we gleaned from our needs assessment inform those prioritized health issues. And then you create your goals. Think of these as your community health improvement solutions. Goals are the tangible ways you'll solve the health issues. Then you can develop strategies which usually take the form of initiatives and measures that specify how you're going to carry out the CHIP. Evaluation, evaluation, evaluation is key. Even though a CHIP spans 3 to 5 years, there should be an evaluation on an annual basis. The Montana DPHHS has funding opportunities for county health departments to conduct their own CHIP. This is a CHIP implementation grant in the most recent cycle. It has since closed. Several of you have been awarded funding for this coming cycle. Congratulations. DPHHS continues to offer CHIP grants annually as part of the public health infrastructure grants. And to my knowledge, the timeframe, the funding cycle will resume at a similar timeframe next year as well. And the public health jurisdiction, or the pot of money, the public health infrastructure fund for DPHHS sits at just over $15 million right now. And there's confirmation that that there will still be allocation of funds from this fund to provide resources for county health departments across Montana to conduct their own, to implement their own CHIP and to write the report. Mental health expansion comprised our CHIP grant application. We have done this by picking Bridger in Montana because the superintendent principal in the Bridger Public Schools is already invested in expanding mental health screening, a referral system, and services to schools. Mental health being the quintessential focus because it was one of the key health concerns that was gleaned from our needs assessment. We connected with the Mental Health Center. They confirmed a plan to allocate extra clinicians for this project. Of course, there are issues with parent and community perceptions. So we aim to provide screening services for students and the community at large. The superintendent in Bridger is working with the Carbon County Health Department to consider the plan and the layout of the screening. The schools are being used as the iterative process before rolling out into the overall community. Because in the community, there are logistical and cultural challenges pertaining namely to stigma and identification. So the county commissioners are preparing space for mental health services within areas of the community that control for these challenges. The Mental Health Center is also providing in-person assistance. The evaluation is planned to consist of total screenings, total positive screens, and total referrals. Bridger is a test of feasibility. The objective is to roll this out to the overarching county as a whole. And I want to make note that this plan has a lot of stakeholders. You want to get all the experts to the table. We have folks with the Carbon County Health Department, a subcommittee of Crisis Coalition, the Carbon County Commissioners, the superintendent and principal in the Bridger Public Schools, the public library director, a facilitator and somatic coach who has provided wellness interventions to students in the community for the last several years, the executive director and clinical director of the Mental Health Center, research affiliates with an outside research group, and community members, advocates, students, and parents in the community. You want to have as many folks at the table as possible. It will strengthen the scientific rigor of your work because you want to. There's great benefit in pooling the resources. This is an example of taking the limited resources in rural health systems, but then using them in the aggregate. This was a CHIP grant that we submitted for this upcoming or for this current cycle. This was our initial timeline back in 2022 when the Carbon County Health Department first posed the notion to do this needs assessment, the completion of stage 1, 2, 3, 4. And then since the completion of stage 4, when we finished in August of 2023, there has been a lot of additional efforts done. Right after completing the final needs assessment and after presenting it to the community, we went to the Aging in Place conference, which was done at a senior center in Red Lodge, where we presented specific results from the needs assessment for the senior community. At that same time, we visited with the Early Childhood Coalition and Rebecca Easter, the facilitator and somatic coach in the community that provided the wellness interventions to students in the community. In the process of doing these things, we were manualizing our implementation of community health improvement. We were not just leaning on the CHIP implementation grant, which we still submitted. Although that submission came back unsuccessful, this is not where we stopped. We also had not had the community health needs assessment fully approved and completed by the time that we submitted. So there were some programmatic challenges to that. But this is an example of how you don't stop at the needs assessment, and you don't stop with an unsuccessful grant application. Because from visiting with the Early Childhood Coalition, we have now branched an entire project to examine childcare in a more fluid way in the community. With the Red Lodge Area Community Foundation, with the Early Childhood Coalition, we have constructed and are in the process of implementing a childcare assessment to examine the resources needed for the new childcare center that was built in the last year in Red Lodge, the Meadowlark Childcare Center. About 2 months after that initial kickoff meeting, we've conducted flagship interviews with the largest employers in the community and have since launched an employer assessment with an employee assessment running in tandem, so we can have a better sense of the specifics in and around childcare needs. Additionally, with this mental health expansion, we've been able to triangulate the resources that Rebecca Easter has done, providing the wellness intervention to about 200 kiddos in Red Lodge schools across the county in the last several years. We did an evaluation on the work that she did, and we are now connecting that work with the mental health expansion project. This goes to show that in rural health systems, we need to work together. Community health improvements is not something that is achieved by one specific individual. You as an individual, whether it be at a health department or an independent organization, are one piece of the puzzle, albeit an essential piece, but one piece at that. We have to remember that rural areas comprise 20% of the population in the country, but only 10% of the resources. That is not setting us up for the success that we all seek. We need to work together. And it is okay to not know what you're doing and to make mistakes. My entire career has been peppered with mistake after mistake. And I think that a lot of public health professionals have experienced similar drawbacks in different avenues of their work. But in public health, we're a team. We are inherently disciplinary, and we are stronger when we work together. There's about 5 minutes left. I apologize for getting a little close to the hour here, but this is the final pause. Would anybody like to share their experiences with a community health needs assessment of their own or a community health improvement plan in their communities? Any questions for me or the overall group? Yes, please, Emily.
Great. Hi, thank you for that. That was really useful. So I don't have anything about my own experience with a community health needs assessment, but I did have a question about one of the graphs that you showed.
Yes.
Would it be possible to look at that? Okay, great. So it was your co-occurrence between substance use and mental health.
Yes. Let's.
I just wanted to make sure I understood what you were showing on the x-axis and y-axis.
Of course, of course. Let me get back to the slide.
Yep, that one. So bottom right.
Yep.
Okay, so on your x-axis, you have, which outcome is that?
Yeah, this is substance use. So 33% of individuals with poor mental health indicated that they have not at all issues with substance abuse.
Okay, so then 56% of individuals who indicated that they had excellent mental health
Have no issue with substance abuse, correct?
have no issues. Okay, great. Thank you. That was all.
Yeah, of course, of course. Yeah, it's all. My apologies that wasn't abundantly evident. Any other questions? Does anybody have anything to share regarding their own needs assessments, their own CHIP? I know several health departments here are in the process of rolling one out, trying to figure out data collection. Let's see here. Stephanie notes that our members have helped in Glendive in the past and currently in Red Lodge with implementation and evaluation of their assessments. If you're interested in getting help, please reach out. Absolutely. Would love to connect, Stephanie. Thank you.
Nick, Raven has a question.
Oh, my apologies. Go ahead, Raven.
Sorry, I got disconnected. I don't know if anybody called on me. Like it recycled and then popped the screen back up. I have no idea what happened right when I raised my hand. Like it
No
froze.
worries.
Cycle. Have you guys been doing any assessments on involving actual community involvement? I mean, reaching out to business owners to help and actual homeowners, whatever, individuals specifically to take part in their own community. I mean, are you doing? I mean, I know a lot of. Look, I lived in Missoula, homeless for the whole last year up until November this year. Getting help of any kind in any demographic is hard. When you're I have limited substance problem ever, other than what medications a doctor's given me. I've had mental health. I was abused and I was just kicked out of my home by the police. Okay. And when you go to look for resources and you're going to do this stuff, you go to these professionals like you guys, like me, because I was in the field when this happened. I was working as a peer support specialist and I was studying homelessness just before that. So it's really funny that it happened ironically to me. Anyways, you guys study like this community involvement. You're talking about like all the professionals and you're saying individuals to us, but what about your individual neighbors? Do we, I mean, is there any assessments going on that bring together community more, that are plans implementing to make us involved in our neighbors and I mean, I'm not talking about nosiness, obviously, but I mean, what harm does it do to like find out if it would improve mental health if your neighbor knocked on your door because they had seen you leave your house in 3 days? Are we working on things like that, like peer and human driven support and community involvement?
Yeah, no, Raven, thank you for that. Yes, there have been efforts in the wake of the flooding that came about. There FEMA worked with the mental health center in Billings and then went out to communities in Red Lodge. And there was actually some door-to-door interaction just saying, how you going? How are things? What's going on in your life? Kind of just a very open framed examination of the overall health and well-being, a pulse on the well-being of the community, doing it in an individual touch point. The mental health center is integral in the piece of our mental health expansion, with an attempt to cross-tabulate all of our measures of screening with referrals and all that with the human experience gleaned from the community itself. So I can speak to that personally for the project I'm working on. But I think that I'm glad you mentioned it, because that component is often what is wanting with so much of our efforts done in the like at the community level. Does anybody else have anything to share regarding that? Raven, I'm more than happy to follow up as well to discuss with you some of the more specifics in and around that process for what we're trying to roll out over in Carbon County. Would love to share and get more of your thoughts if you'd like to connect.
That would be excellent.
Lovely.
I would love to connect more and bounce ideas off people's brains. I'm a knowledge sponge. I love to learn new things, and I love it through other people. I'm more of a hands-on learner than a textbook person. I can read the information and memorize it, but I'm not going to actually understand it till I'm in the depths of the mess. I'm just not going to get it. It's just going to be words on a page until I'm doing it. So I would definitely love to pick your brains and stuff. I know it's a little off I know it was a little off topic in some ways, but it's one of those things I see all these things, and everybody talks about community, but all they're talking about is people with acronyms behind their name, or who own something, or who have a wallet that isn't empty every day, or have access to a shower every day. You're not asking the regular humans who are out there. And that's something that, until I experienced it again as an adult, I didn't realize how much that matters, is having somebody that you could just, other people. And the other part of, and I know this is way off topic too, but in the mental health field, people need to consider after hours consulting, after hours fucking counselors and therapists and people like that. Because when everything's set to 9 to 5 and you don't have anywhere safe to go at night, who do you talk to? So I'm sorry to bring this up, but all this stuff, and you're talking about acronyms. I'm sitting here thinking, all the people I went to acronyms. I have no criminal history, no drug problem, no nothing, and I couldn't get help from anyone who had an acronym behind their name. Not a doctor, not a peer who was in the field would help me. So if you want to help people, you need to be people and bring people in, not just acronyms. And community means a lot more than people with acronyms.
Not off topic at all, Raven. That was probably the best culmination of what community health improvement planning is all about. To really to meet people in the community, to meet people where they're at. Public health is inherently multidisciplinary. Our best value to ourselves in our professional roles is through the on-the-job, off-the-cuff learning. The textbooks will certainly provide their value, but our roles in the community themselves and our experiences there is what gives us the edge and strengthens us in our respective positions. So thank you for sharing. Does anybody else have any other questions, queries, thoughts? Very well.
I have another one. I know that we're to time, but I just was curious from your perspective, what you find from all of the steps of the community health needs assessment, What step do you find to be the most challenging, and which one do you find to be the most rewarding?
Oh, thank you, Emily. That's a loaded question. No. I would say the answer is the same for both. The efforts to make things as community led were sometimes programmatically cumbersome, and oftentimes when you bring so many voices in, it can sometimes convolute, or it adds complexity to the overarching picture at times. Like as I showed you all, with so many stakeholders in the mental health expansion project, sometimes when you pool so many resources, there could be efforts or entities that might be, I don't want to say conflicting, but there might be visions that aren't directly aligned. And that is both the most challenging, but the most rewarding when you can actually succeed in creating the shared vision. That third component of the chip is arguably the most difficult one, I believe, to really create a consensus. Without divulging too much detail regarding the childcare assessment that we're doing, which is in process. That's why I don't want to speak too formally on the topic. But one of the biggest challenges that we have experienced is the fact that there are several different childcare centers in the area, and not all of them operate on the same continuum. This new childcare center that is being launched is being overseen by one particular entity, but there are other stakeholders and members on the Early Childhood Coalition who are operating in a different space with respect to childcare, and they don't necessarily view not everyone views childcare in the exact same light, which makes the consensus of a shared vision sometimes logistically challenging. So does that answer your question?
Yeah, it does. Thank you.
Of course. My contact information is right there, everyone. I'm going to email you all, drop a line, share with you the PDF of the needs assessment, just so you have it in your pocket. And feel free to email, call. I would love to work with you. I would love to connect. If there's any means to collaborate, I would very much like to. So thank you all very, very, very much, and have a wonderful Thursday.
Thank you, Nick. We really appreciate your presentation today. Have a
Thank
great
you.
day, everyone.